Hello everyone, my name is Dr. Andrew Prieto and I'll be discussing the 2020 ESC guidelines for the management of ACS in patients presenting without persistent ST segment elevation. So these are patients that are basically in for unstable angina or non-ST elevation MI. So just like to start with a brief overview of the diagnostic algorithm and triage of patients with ACS. So we're supposed to look at four different variables to diagnose a non-ST elevation myocardial infarction. The first is the clinical setting, symptoms, and vital signs, and then the ECG, then the troponin level at 0 hour, and then the troponin change within 1 to 3 hours. After getting these four variables, we're supposed to be able to triage the patient into rule out MI, which is majority of the patients, and then MI ruled in, either non-STEMI or STEMI, and then about 30% will fall under the gray zone where we still do not have a definite diagnosis after the four variables have been considered, and these patients are for observation. Typically, you would be getting maybe an echocardiogram or a third troponin level. So at this point, I'd just like to, I guess, lay out some ground rules on how the recommendations are being given. There are three classes of recommendations, 1, 2, and 3. Class 1 recommendations are those in the green color, and these are recommendations that are generally recommended and indicated. Class 2 are in yellow and orange, and these are recommendations that are 2A should be considered or 2B may be considered. And then the class 3 recommendations are in red, and they are not recommended. Now, all these recommendations are just recommendations. They're not set in stone, so it's really up to the physician to make the final decision, especially after discussing the procedure or treatment with the patient and or caregiver. Now, there's a lengthy number of recommendations, and it would probably take up more than an hour to go over those recommendations. So I'm just going to go over the new recommendations, and in particular, I indicated with a blue star those recommendations that are important, or maybe recommendations that we don't do at all or don't do enough in our institution. So the first recommendation, as an alternative to the ESC 0 and 1 hour algorithm, it is recommended to use the 0 or 2 hour algorithm using high sensitivity troponin test for the diagnosis of non-STEMIs. So I believe in our hospital, we do more like a 0 and 4 or 6 hour algorithm where we actually probably wait for the results of the first troponin before drawing another troponin. But they recommend at 0 and 1 hour in the 2015 recommendation, and now in the 2020 recommendation, a 0 and 2 hour rule out protocol, where the lab draw is drawn at 0 hours, which is the time when the patient comes into the emergency department, and at 1 hour from the time the patient arrived in the emergency department. So it really doesn't matter how long the turnover time is for the results to come. It's more important is when the lab draw is drawn. And depending on the value of the first troponin and the second troponin, if there's an elevated first troponin or a significant change in the troponin level, then MI is ruled in. Otherwise, MI is ruled out, and if it's in the gray zone, then patient is for observation. So if you've ruled out MI, most of those patients can be discharged. Ruled in goes to the CCU or the cath lab, and observation goes to the ward. And here's another way of putting it: if you're negative, you're in the green, zone and you've ruled out MI. Otherwise, you've ruled in MI, and there's also another group that's for observation. And so the green group has a very low risk of myocardial infarction, less than 0.3%. The high risk group, more than 65% of those will rule in for a type 1 MI, and intermediate risk about 10%. Now, the second recommendation is for diagnostic purposes, they are recommending not to routinely measure other biomarkers such as CKMB. We still do CKMB blood draws for other reasons, but not routinely is their recommendation. And that's a class 3 recommendation. Now we have a couple of class 2 recommendations, 2A recommendations. First, measuring BNP levels should be considered to gain prognostic information. So that's quite straightforward. BNP can be a surrogate marker for the Phillips classification, which is a very good prognostic risk stratifier that can help tell whether a patient is having congestive heart failure or pulmonary edema. The next recommendation is also with a blue star, because I think this is important to know, although it is still quite controversial. That's why it's in the yellow color. And they're saying here under antithrombotic treatment that prasugrel should be considered in preference to ticagrelor for non-STEMI patients who proceed to PCI. So this was borne out by just one trial, the ISA React 5 trial, which involved over 4,000 patients. It's a multicenter randomized open label trial. It's published in the New England Journal of Medicine 2019. And here is the Kaplan-Meier curve for patients who present with non-STEMI who proceeded to PCI. And the triple endpoint of death, stroke, and myocardial infarction was in favor of prasugrel compared to ticagrelor when followed up to 12 months. Now, it's a little controversial because it's not only a difference in medication that was tested, but a difference in strategy. See, prasugrel was given only in the cath lab when PCI was planned due to the coronary anatomy. Ticagrelor, on the other hand, was given earlier upon the diagnosis of the non-STEMI. So, so that's why there's a little controversy here. But having said that, prasugrel did do better in this study, and so it has a class 2A indication. Also, we have to mention that prasugrel has a black box warning for patients with a history of TIA or stroke. And the maintenance dose also should be lowered for patients who are elderly, greater than 75 years old, or who are of low body weight. Next recommendation is in red, and this states that routine pre-treatment of P2Y12 inhibitor should not be administered before the coronary anatomy is known in patients who are going for early invasive management. So I think we routinely give the P2Y12 inhibitor in the emergency department once we know that there's a diagnosis of non-STEMI, and they're saying in this recommendation that is not something that we should be doing, and that's from the ISA React 5 trial and other trials like the COAST trial and some registries, which even looked at clopidogrel, that more harm can be done giving the clopidogrel early because of bleeding complications without much significant improvement in ischemic complications when the patient is brought to the cath lab within 24 hours. So um, I think that's a little controversial, but that's what they're recommending in red here, which is a class 3 recommendation. Now, they do say in the very next recommendation here in orange, 2B recommendation, that if the patient is not going for an early invasive strategy, that you can give the P2Y12 receptor inhibitor. There's another recommendation below that, de-escalation of P2Y12 inhibitor treatment can be given or done when you're switching prasugrel or ticagrelor to clopidogrel after the acute setting. And I think a lot of physicians like to do that, mainly to decrease the cost of the medication, and that after 1 month you can de-escalate from prasugrel or ticagrelor to clopidogrel. The next set of recommendations are under antithrombotic treatment. For patients with atrial fibrillation, which is about 4 to 8% of the patients who present with a non-STEMI, they say that a short period of triple antithrombotic therapy can be given for 1 week from the acute event, and then downgraded or de-escalated to a dual antithrombotic therapy. And this dual antithrombotic therapy usually involves a NOAC and an oral antiplatelet agent, preferably clopidogrel. And this is borne out by several randomized studies to be safe and effective. Next, we have another recommendation in green, that the antiplatelet treatment in patients with the OAC is recommended after 12 months. So after 12 months, you can drop the clopidogrel and just leave the patient on either the NOAC or vitamin K antagonist. And there's also another provision, this time in orange, 2B recommendation, that instead of using triple antithrombotic therapy, you can do dual antithrombotic therapy, but instead of clopidogrel with ticagrelor or prasugrel. Next set of recommendations is under invasive treatment. An early invasive strategy within 24 hours is recommended in the following patients. Number 1, diagnosis of non-STEMI. So this is type 1 myocardial infarction. And then those with dynamic or presumably new contiguous ST segment T-wave changes, those with transient ST segment elevation, and those with a Grace risk score of greater than 140. And a selective invasive strategy, on the other hand, is also recommended by those who have abnormal ischemia testing or coronary CTA in low-risk patients. For those of you not familiar with the Grace score, it's basically looking at several variables, which include the Phillips class, systolic blood pressure, heart rate, age, creatinine, and other risk factors. And they add all these predictive factors, and you get the total Grace score. And a Grace score of greater than 140 is the cutoff for a patient who they feel is a candidate for invasive management. And that equates to a probability of in-hospital death of 2.9% or more. Next, under invasive treatment, this is the last slide for the recommendations. A delayed as opposed to immediate angiography should be considered in hemodynamically stable patients without ST segment elevation who are successfully resuscitated after an out-of-hospital arrest. So if there's no ST segment elevation in a patient with a cardiac arrest, there's no need to rush to the cath lab. The next recommendation, complete revascularization should be considered in patients with non-ST elevation myocardial infarction and multivessel disease and without shock. and that complete revascularization should be done during the index PCI um, if possible. So they're trying to dissuade patients with multivessel disease, dissuade the strategy of leaving the other non-culprit vessels alone for a staged procedure. But this is only from small non-randomized studies, so it's a 2B recommendation. And then the final recommendation, also 2B, is FFR-guided revascularization of non-culprit, non-STEMI lesions may be used during the index procedure. Just to show you what an FFR is, this is where we cross the lesion with a wire, and the wire has a pressure monitor at the tip, and it compares that pressure to the pressure in the aorta from the catheter after giving adenosine and adenosine bolus. And usually what happens is if the lesion is significant, you have a drop in the FFR, and a drop of less than 0.80 is significant for a significant lesion. And the studies have shown that at that cutoff, if it's less than 0.80, that you should treat the lesion because they will have more events in the future. If it's more than 0.80, then you should defer the angioplasty as they will perform just as well with um, medical therapy. Okay, this is my last slide. Just a summary slide. The First of all, number one, 0 and 1 hour or 2 hour troponin algorithm is recommended in triaging patients being considered to have ACS in the emergency department. Number two, hierarchy of the P2Y12 inhibitors during the acute setting are prasugrel better or equal to ticagrelor, which is better than clopidogrel. And then, if early invasive management is planned, pre-treatment with a P2Y12 inhibitor and when the coronary anatomy is not known is not recommended. Finally, in patients with atrial fibrillation requiring antithrombotic therapy after PCI, a combination of a NOAC and clopidogrel is recommended after a week of triple antithrombotic treatment. And that's all I have for the 2020 ESC guidelines for ACS non-STEMI. Thank you.
Thank you, Andrew, for that very extensive review. Basically, we got a lot of the meat of the 2020 ESC guidelines. And as Dr. Paul mentioned earlier, this will be practice changing updates, no? So just to get the ball started, we used to have a 0, 1 or even 0, 3, 0, 6 hours for the troponin I. Now it's recommended to have it 0 and then 2 hours. So this practically will change what we actually do, especially at the ER level. No, so can you expand on it?
Yes, thank you, Joel, and thank you for inviting me again. Yes, the troponin currently is high sensitive, so very little change is detected right away. And so if you do a 0, 1, or 2 hour, you have a much quicker diagnosis of a non-STEMI.
So quicker turnaround time, quicker decision making also. That's very good. So that's one of the very important updates we got from these guidelines. The other thing, it's sometimes we see patients at the ER and then they call us and then they already loaded with clopidogrel 300. So what the guideline is telling us, if we plan to do early invasive strategy, is you shouldn't do this practice, correct? Is that correct?
Yes, that's right, Joe. Now we have to differentiate STEMI from non-STEMI. STEMI, you can definitely still give it at the ER, But a non-STEMI, the studies have shown registries for clopidogrel and the COAST trial for prasugrel, and then registry for ticagrelor, that there is more bleeding risk than benefit, ischemic benefit. So wait, especially if it's within 24 hours, wait till the patient has the angiogram. If you are going to proceed to PCI, that's when you give the
Yeah,
P2Y12.
because sometimes we get it that sometimes we already loaded with a lot of blood thinners, and then suddenly the patient will have to undergo surgery, and with all the blood
Yes,
thinners on board, we have to hold the surgery a little bit, and hopefully nothing happens in between. So if there's an early invasive strategy planned for NSTEM, is that correct?
yes. Personally,
NSTEMI.
that's actually the most problematic issue I encounter, and that's when we find, especially here in the Philippines, a lot of advanced disease
Mm-hmm.
that they need surgery, and all we have to hold off, or even if we don't hold off the surgery because it's urgent, there's now more bleeding complications during the
Okay.
surgery or
Very,
after.
that's a very good update for all of us. The other question I have is that um, before in the 2015 guidelines, when we have patients with ACS and atrial fibrillation, we give the triple therapy for, from what I remember, 6 months for low risk and maybe 3 months for high risk patients. But now with the 2020 ESC guidelines, we can give it for just 1 week, right?
Yes, 1 week.
1 week, and then after that we downgrade to dual therapy, which will include the NOAC and clopidogrel.
Yes, yeah, we
So
usually
this
drop the
is now
aspirin.
different from what we are used to doing before. So 1 week only, and then we downgrade right away. So very very important update, right? And then let's see if we have questions from the chat box. So none so far. Oh wait. Oh, we have one from Dr. Melissa Bernardo. What if we do not plan early invasive? Do we load?
Yes, there is a provision in yellow 2A that you can give the clopidogrel or whatever P2Y12 inhibitor if you're not going for early invasive. So that's allowable.
Another question we have here is that you mentioned about FFR, fractional flow reserve. So this will help us guide if we have to do revascularization or not. But in real practice, in the real world, do we really have to do it? One factor that somehow limits its use is the cost. How much will
Yes.
it cost to do the FFR just to decide on whether we have to do angioplasty or not? Because, you know, when we undergo all these procedures, it's already quite expensive, and adding FFR to it will really benefit us, especially in the Philippine setting.
Yes. First of all, unfortunately, we don't have FFR readily available in Makati Med. No, we have to request for it ahead of time, especially for elective procedures. So definitely emergency procedures is not yet available. And if it's available, it costs about the cost of a stent. So it's about 40,000 to 60,000 pesos. And but I believe it's very useful, especially in borderline lesions. Not all lesions, but just the borderline where it looks 50% to 70. You're not sure. And what I did find out in experience with the FFR is if the vascular bed is a large bed like LAD territory, even a 50% lesion could be positive. Then uh, if you're dealing with a small branch, even if it's a 90% lesion, if it's a small branch, it will be negative. So I think it does tell us that the impact of angioplasty or revascularization is larger if it's a big territory.
So indeed, it's very important because the extent of stenosis will not matter depending on the FFR. We have one question from Dr. JD Foronda. Was clopidogrel resistance a big consideration in the 2020 guidelines?
Yes, it was a 2A. It was not in the new list, but yes, they do say that there's a some benefit, but not a class one recommendation for genetic testing or testing, in vitro testing of the platelet activation with the different P2Y12 inhibitors. It I think has some benefit, but apparently in one of the trials it did not show that it was affecting the actual outcome. But definitely outcome as far as if you changed because due to the test. But the test can predict who would be more at risk for thrombosis.
Okay. Dr. Andrew, you mentioned about complete revascularization. I remember there was a trial before. I'm not sure if this is the basis for the 2020 guidelines about the complete study,
Mhm.
wherein before you have to choose whether you will only do the index lesion, the one that caused the myocardial infarction. So sometimes we have multivessel disease where we have to choose whether we have to do the culprit lesion or we'll do everything that's there. So can you expound on this, sir?
Yes, the complete study is a small non-randomized study. So there's a lot of these small randomized and small non-randomized trials. So we're still looking for a big trial to justify the treating all the lesions. But they did say in the complete study and other small studies that doing all the vessels and particularly doing it all during the first procedure, not even staging it on a second procedure, has more benefit as long as the patient does not have shock, that to do all the lesions all at once. And I think it's also maybe more cost effective, especially here in our local setting, that we treat all the lesions possible in that one procedure.
Thank you for that. We have two more questions. One from Dr. Melissa Bernardo. Any cutoff in the rise of troponin after 2 hours to identify who will most likely need early invasive treatment apart from the other factors enumerated?
Yes, I failed to show that, but there's actually a table. It all depends on the titer that you have, the assay that you have in your hospital. But there's a cutoff for the 0 hour, and then there's a cutoff for the 2 hour change. How much change there is depending on the assay. There's a table in the ESC app or the guidelines app. You can
Oh,
just
that's good to know. Maybe Andrew, you can share it to us maybe in the chat box or uh in other platforms where we can get a look into that. Or maybe we can just check the ESC guidelines. It's there.
yeah. I'll
Yeah.
try to link the attachment of
Okay,
the.
thank you for that. We have one question from Dr. Versosa. When do you use FFR versus optical tomography, and what is the advantage or disadvantage of one over the other?
That's a very good question, especially because these are all costly procedures. But the OCT or the IVUS, intravascular ultrasound, are anatomic test, while the FFR is a functional test. So if you want to do something like a stress test in the cath lab, then you do an FFR. But if you want to really look inside, particularly for stent sizing, then I would use the FFR or the OCT. For the decision of to whether to treat a lesion or not, I think FFR is more valuable there.
Okay, so if cost is not an issue, you can actually do FFR instead. Okay.
Yes, if you're trying to decide whether to treat a lesion or not.
Okay. So far, no more questions here. That we got these very important updates. Thank you, Dr. Prieto. I'm sure we learned a lot of things with this lecture. So far, we have two very important lectures. We got very important updates and the practice. Thank you, Andrew.